All right, 12:01 on the dot. Thank you so much to everybody who decided to come join us today. I'm excited to say this is our very first launch of our Region 8 Disaster Health Learning Community for our ECHO grant. So we're really excited to have you here and be part of the process. Just to get started, my name is Ariana Boschera. I am a project manager with the Project Echo at Denver Health. And I'm joined today by my coworker, Katie Bristol, who I'll pass off to introduce herself here quickly.
Hi everyone, my name is Katie, and I'm also project manager at Denver Health supporting the Project Echo series for the year.
Thanks, Katie. And then would also ask you to go ahead and just enter your name, role, and organization into the chat if you'd like, just so we can all get a better idea of who's joining us today. So just a few quick introductions on what Project Echo is. I'm sure most of you have probably heard of this project before, but in case you haven't, Project Echo is a case-based virtual learning model that connects experts and practitioners through telemonitoring and webinar series. They are built on the principle of all teach, all learn, and they focus on getting the right knowledge to the right place at the right time. So, why are we using the Echo model? So, they have done a lot of work to make sure that it reaches all corners of communities. So, they expand access and expertise. They promote consistency, best practices, and we work to build professional knowledge and confidence and reduce isolation and inequities. And also just focusing on rapid diffusion of critical information that we might not be able to otherwise get. Just a very quick overview on a little bit of background on this project. Just since this is our very first webinar, we wanted to introduce Echo and the grant a little bit more. Um, but this is a subaward through the Echo Institute and Robert Wood Johnson Foundation. We're going to be hosting live biweekly sessions like today for 18 total sessions running from January to September of 2026. So this is actually throughout the entire country. Um, but our regional focus will be in our HHS Region 8, which is Colorado, Utah, Montana, North Dakota, South Dakota, and Wyoming. So again, our purpose of this is to build a regional community of practice for emergency preparedness, and then strengthen collaboration across healthcare, public health, and emergency management professionals like yourself. So we'll be doing some case-based discussions, resource sharing, and just highlighting some regional challenges and solutions to these emergency management and disaster health problems and scopes. Just a few quick disclosures. We do not have a grant subaward number quite yet, but that is coming, but we are funded through Robert Wood Johnson Foundation. The content of this presentation is a product of the individual presenters and does not represent the official policy of the United States government. This information is not meant to be a substitute for professional medical advice, diagnosis, or treatment, and the presenter has no relevant financial interest or relationships to disclose. All right, speaking of our presenter, I'm very excited to have Dr. Franchos here. He is a board certified surgeon with extensive experience in trauma care, emergency response, and mountain medicine. He earned his medical degree from George Washington University in Washington, D.C., and completed his general surgery residency at the University of Colorado Health Sciences Center. Dr. Franchos served as an attending surgeon at Denver Health and Vail Health from 1995 to 2022. He has also held leadership roles as medical director and director of research and development for strategic operations in San Diego, California. In addition, Dr. Franchos previously served as medical director for Vail Mountain Rescue, tactical medic for the Eagle County Sheriff's Special Operations Unit, and medical director for the Vail Ski Patrol, bringing deep operational and field-based expertise to high-risk environments. So we're extremely excited to have him here. And with that, I will pass it over to him. If you have any questions during this presentation, please feel free to enter them in the chat or just come off mute and ask away. We're happy to have you here and want to hear your feedback. So, Dr. Franchos, I will pass it to you.
Thank you. I want to thank you all for allowing me to make this presentation. I know it's their first um, presentation of this series, and when Dr. Young told me about it, I thought it was a great idea for those of us who live in more rural areas, although Vail I would call more recreational than rural, but it still has the issues of time and distance and bad weather and limited resources that we all experience. And I think that spending your time in these places, you learn a lot about how to take what's generated from large institutions and apply some of it to your smaller institutions, and also importantly figure out what's just can't happen at a smaller institution, um, which we'll get into. As you can see from my bio, I've spent a lot of time trying to figure out how to get out of the hospital and into the outdoors, and I'm kind of proud of that. And so they asked me to start with a case presentation, and I think this case presentation very much represents the sort of system you can develop by really understanding your regional resources and what all of us, each one of us, each component has to contribute. So next slide, please. So Vail is located in the central mountains of Colorado, where the red arrow is. You can see the distance from there to Denver. Our usual level 1 trauma resources, Denver Health, it's about 110 miles. You go through two 10,000-foot mountain passes. So I like to say when the road is dry, it's about an hour and a half. And when it's snowing hard, you might as well be in Shanghai. It's a level 3 verified trauma center, 19 bed ED, 56 bed hospital, 5 main ORs. And our alternative when we cannot go east, which is not infrequent in the winter, is to go to Grand Junction to the west, which is a highly capable, verified level 2 trauma center. Next. So this patient was brought in from ski patrol. Offhand, it didn't seem like a very impressive sort of or a high mechanism. This is the kind of patient we see regularly. I mean, really, you would call this garden variety ski trauma. So 49-year-old male, very experienced, helmeted skier, skiing backwards on a beginner's run with his young daughter, encouraging her, teaching her how to ski. He again was skiing backwards and he lost control, striking his back against a tree. Ski patrol was called. He was A&O times 3 when they got there. He had severe thoracolumbar spine pain, so they figured he had a spine fracture, best guess, and maybe some rib fractures. They put him on a scoop and toboggan for transport. They did not want to roll him. Next. And you can see where the red crosses in your upper right hand that's Lost Boy. That is a beginner's run that goes down into the Game Creek Bowl. So you have to load them onto the chairlift there, bring them back up to the top, and then ski them down to the skier transport pickup and then to the hospital. So I would estimate that's, I don't know, 30 to 40 minutes from time of injury to the ED. So pre-hospital EMS, blood pressure is 106 over palp, heart rate 104, respiratory rate 20, 86% on room air, but pulse ox is not perfectly accurate when people are cold. His GCS was 14. He was interacting. He was complaining of severe thoracolumbar pain. He got 200 micrograms of fentanyl, which improved this. Again, EMS thought probable spine fracture, rib fractures, moving his lower extremities, no evidence of neurologic compromise. Again, pretty garden variety to us. I use that term loosely. No, he didn't meet even level 1 activation criteria for any reason. EMS activated the level 2 trauma alert because of the level of pain, which means the ED physician meets the patient on arrival and decides whether he wants to add trauma team notification. He or she, ED doc. In the emergency department, his blood pressure was 90/57s, was not tachycardic, pulse was 88, respirations had slowed down with the fentanyl. SAT was improving, although that's a little low for 2 liters. No nasal cannula, a little bit cold, still alert and oriented ×3 with a GCS of 14. Complaining of abdominal pain with low back pain, airways patent, respirations normal. Right posterior lateral inferior thorax was quite tender. Lung sounds present, clear bilaterally. Abdominal exam soft, minimally tender. Pelvis was stable. Again, not very impressive. So he was ordered for a CT scan of the chest and abdomen. Chest x-ray taken before that was unremarkable. Maybe some right lower rib fractures, 10 and 11. Next. So this is the CT scan that came up. Again, we did not accompany him to the CT scanner, which someone would have if it was level 1. There wasn't much of a worry, but as you can see to the right, that stripe around the liver, that's blood. And he's got blood accumulating down into his pelvis and some more blood in the lesser sac. However, what's not apparent is no evidence of a spleen injury, no evidence of kidney injury, and no evidence on first pass look of a liver injury. So on first pass, there's really not an explanation for this blood. Next. However, the radiologist called the ED physician and said he's got a moderate hemoperitoneum, and again, no obvious identifiable source of the bleeding. Makes you think maybe a mesenteric vascular injury, but now his clinical situation begins to deteriorate. His blood pressure is now below 90, 87/43. He's getting tachycardic. He's starting to really pant, although he's maintaining his SATs. And again, he's still ANO ×3, but now he's got abdominal distension and starting to show signs of shock. It is snowing significantly. There's no chance of air medical transport. Again, air medical transport, when we can fly, will get us into one of the Denver level 1s in 35 to 40 minutes. The ED physician decides to change his status. He calls it level 1 trauma activation, which gets us a lot more resources immediately concentrating on the patient, and also alerts the trauma surgeon, who now needs to be present at the bedside within 20 minutes. We were already down there doing other things, so as soon as they called it, we were able to take a look at the CT scan. Next. So what now? We can't fly. Estimated time if we went by ground, would be 2.5 to 3 hours. That's if one of the passes doesn't close. And one thing that we've learned over the years is we are better in the hospital with some limitation to our resources than to be traveling when we don't know how long it's going to take or whether we can get there and how much blood we would need if we need blood, et cetera, et cetera. Anybody have any suggestions or thoughts at this point about what's going on? Okay, next slide. So we notified the OR and anesthesia that we felt that he needed at least to have exploration, especially since we had no idea where the blood was coming from. One of the anesthesiologists and eventually a second one came to the ED to assist us with resuscitation. He got two IVs, but more importantly, we were able to put a right-sided cordis in place while we were waiting for one of the operating rooms to come down. And we were able to get to the operating room fairly quickly. Now, at this point, since we had no idea where the blood was coming from and he's showing signs of shock, we activated our massive transfusion policy. And I want to slow down and talk about MTPs a little bit as they actually occur in rural or resource limited environments. Next. So, as you know, whole blood is the holy grail under these circumstances. At that time, we had no whole blood available, although some eventually did come with the critical care transport. And so ideally, if you're using component resuscitation, you want to get somewhere around a 1:1:1 packed red blood cells, FFP, and platelets, or Denver Health is more a 1:1:2. But either way, my point is this doesn't really happen in our environment, and I'm sure for most of you. For instance, we don't have platelets. Part of our massive transfusion policy is to ask for some platelets to be brought to us from one of the local hospitals. Either way, whether we get them from the east or the west, that's at least an hour turnaround before we see any platelets. We do not have fresh frozen plasma thawed, so it needs to be thawed. Our usual air transport, Flight for Life now, does carry 2 units of whole blood. And now, actually, Eagle County Ambulance carries the supervisor has 2 units of whole blood available that can be given in the field or in the ED. And we do have TXA available, but we do not have a TEG. And as you know, some people feel that without some sort of evaluation of the clot through some sort of thromboelastogram, you don't know whether the TXA, while in most cases it would be beneficial, in some cases it actually is deleterious to patients that are already hypercoagulable from their shock state, probably about 15% of trauma patients. Next. So this is the board outside the cooler in the laboratory that we keep all the time, and that gets adjusted every day, or really anytime there's a transfusion. I just took a photograph of that last week. So on the average, we have about 20 units of, we have about 30 O units. About a third of those will be O negative, about 10, and about 20 O positive, some A negative, and some A positive. Again, it changes constantly, but that's the ballpark. We have about a dozen FFPs, and we have no platelets. When the MTP is initiated, the blood bank coordinates with nearby facilities to obtain some platelets, and that's 1 unit at a time, and that's at least an hour of turnaround time. And we do have 5 units of cryoprecipitate on the average in the hospital. Now, because we have to thaw the FFP as soon as we start call for that massive transfusion policy. Next slide. And there's the water bath, which will take 4 units of blood or 4 units of FFP or 2 units of blood and 2 units of FFP. And we also have another 2-unit water bath next to it. So we could get 6 components and any combination of blood and FFP thawing at the same time, but you're looking at 20 minutes before the first unit becomes available. And as you know, when somebody is exsanguinating, 20 minutes is a long time. And what we actually have available is really 2 units of O components that are of O negative that are thawed. We can start with that. So I would say that, given this situation, when you start looking at the numbers and the times, the best you can do is try to always have some component hanging so that you minimize the amount of saline or crystalloid that the patient is getting. And it's been shown that people who get over a liter, and especially over 2 liters of crystalloid, that have massive transfusion requirements, which is, described differently, but usually at about 10 units of blood, you're considered massive transfusion, that they clearly have a worsened outcome, higher morbidity and mortality than people who can get blood components almost exclusively. Again, ideally being whole blood, and after that, a balanced resuscitation. Next. So one of the things that we've learned and kind of copied from the Europeans, because we have no platelets. So this is the cheat sheet that the lab techs use to get going for the massive transfusion policy. And you notice that they'll start preparing 4 O negatives into the water bath. They'll start thawing 4 FFP and 1 cryo, but they're really only thawing 2 FFP if the 4 O negatives are in the bath. Remember, we have 6 availability to thaw 6 units, whether blood or FFP, at one time. But what we have learned to do is, since the cryoprecipitate packages are very small, you can put them in in the water bath, either with the packed red cells or the FFP. And by mixing the cryoprecipitate in with our MTP, or having the cryoprecipitate also added to our MTP, which larger institutions don't necessarily do, the concentrated fibrinogen in the cryoprecipitate gives additional cross-linking. It's much more concentrated than what's in the FFP, and that that mitigates some of the effect of not having the platelets available. So you offset some of the situation where you don't have platelets available until they show up. Next. And what I would be interested in is anybody out there from a smaller institution have any different experience in trying to get this balanced resuscitation going, or any other tricks like the cryo that you can share with the rest of the group about how you try to offset the fact that you're never going to get that balanced resuscitation 1 to 1 to 1. Anybody got any helpful suggestions? Okay, well, I guess I'm on my own. All right, so we go off urgently to the operating room. I was the only surgeon available at the time, although one of my partners was able to get back in to help me about a half hour into the case. It's right about dinner time now, a little early evening. By the time we got to the operating room, he had a massive hemoperitoneum, and again, did not appear to have a spleen injury, did not appear to have, there was no expanding hematoma in the retroperitoneum on either side, zone 2. No expanding hematoma in zone 1 over the aorta and vena cava. And it appeared that most of the blood was coming from behind his liver. And so we were suspecting a retrohepatic vascular injury, and those are either from the veins directly from the liver into the vena cava, or from the vena cava itself. Either way, that is a very significant life-threatening injury to deal with a limited blood bank. There were significant adhesions from the gallbladder to the duodenum, which delayed our being able to place a Pringle clamp. So we packed as tight as we could while we were exploring, looking for other injuries. And again, with the way that the injury was, or the mechanism was explained to us, this really seemed quite mysterious for what seemed like a very low mechanism. We then decided that we need to perform the Pringle maneuver. And while I understand a lot of people in the audience are not involved with surgery, I'm going to just describe the Pringle maneuver and why this added to the mystery of what was going on for us. Next slide. That's spelled wrong. It's supposed to be Pringle. So the Pringle maneuver is where you get a clamp across the hepatoduodenal ligament. And if you'll see the structures in there, the liver being at the top, go back, leave it on there for a second, please, you have the portal vein and the hepatic artery, which are two of the three blood sources involved with the liver. The third being the hepatic veins, which drain from the top of the liver into the vena cava, and the small venous branches that go directly from behind the liver into the vena cava. Now, all of our surgical lives, when we're training, we're told that you can figure out what's going on by putting the Pringle clamp on. If you put the Pringle clamp on and the bleeding stops, then it's either a portal venous injury or a hepatic artery injury because you've clamped those, or a combination of them. And if it keeps bleeding, then you know that it's going to be from the retrohepatic vena cava or the hepatic veins. So what happened was, when we put the Pringle clamp on, the bleeding would slow down from torrential, and I mean torrential, to just very significant. So we weren't able to sort out what's going on. It kept bleeding whether we had the clamp on or off, but much more vigorously with the clamp on. Next. I'm sorry, much more vigorously with the clamp off. So what we found as we're exploring was a venous avulsion of the superior mesenteric vein to its junction with the portal vein. We were able to repair that. We put a clamp behind it to protect the repair because it looked tentative. We ligated multiple small vessels. We thought maybe we'd gotten in control of this. We were planning for a temporary abdominal closure with a Bogota bag. In the meantime, we knew we couldn't fly. I had spoken to the trauma attending at Denver Health, and we agreed to send the patient packed as tight as possible. However, even with the packing as tight as we could get it, the patient continued to bleed. And the patient would bleed torrentially from behind the liver with the clamp off and still very significantly with the clamp on. So not quite sure what's going on, but we are burning through the blood supply in the hospital and the additional units of blood that the critical care transport team had brought for us. Next. So again, my discussion with Dr. Moore at Denver Health, we talked about the fact that previously twice we've flown patients with a tourniquet on the hepatoduodenal ligament, so a tourniquet Pringle maneuver. And in general, best estimations are that in most patients, the liver will not tolerate more than about 45 minutes of warm ischemia. So in the previous two cases, we were able to pack, put the tourniquet on, put a temporary closure on. Patient was flown directly from the operating room to the operating room. Surgeons are waiting there. And in both cases, while we had drained all the blood out of the hospital, the patient survived both patients survived with normal neurologic recovery, even though that's pretty desperate because the liver is ischemic the whole time. Now, we're still in the middle of the snowstorm, and we realize that it's going to be at least 2.5 hours by critical care ground ambulance. Is my estimation at that time that with the amount of torrential bleeding without the clamp on, that the only way we will have enough blood to get the patient alive to Denver is to have the tourniquet, Pringle maneuver tourniquet on the hepatoduodenal ligament, which means that we're going to be subjecting the liver to about at least twice as much ischemic time as it's known to be able to tolerate, which means that we are going to kill the liver. So the discussion again with Denver Health is, are you sure that you can't pack them tight enough to send them without the clamp on? So right at the bedside on the pram with the critical care ground crew, we took the bag off, packed him once again as tight as I could do without compressing the vena cava. Bleeding torrentially, we're becoming critically low on blood products now, and it's our estimation that there is no way the patient can survive without the clamp on, knowing that we will almost inevitably cause critical ischemia to his liver. And by that time, we had a good estimate of how much he would bleed with or without the clamp. And we also realized that we would run out of blood even with the clamp on before he got to Denver, and that he would exsanguinate in the um, critical care transport, which forced us to contact, or at that point, to overcome that part of the situation, we contacted the state police. A cooler of blood was given to them in Denver, and they started heading west on I-70 with the plans to meet the critical care transport in Denver and transfer the cooler of blood to the transport crew, which we roughly calculated would give them enough transfusion ability to make it to the operating room in Denver. Given the conversations that had occurred between myself and Dr. Moore at the time, Level 1 Trauma Center, Denver Health had the foresight to contract the university transplant team. So now we've had ski patrol, EMS, our hospital, state police, Level 1 resource, and now the university transplant team get involved with this case. Next. The patient was taken immediately to the operating room at Denver Health. But prior to leaving us, again, I already said we tried to remove the clamp. We were unable to do that. We repacked them on the pram. We had to replace the tourniquet. And as the patient, remember, we usually have about 30 units of blood. And as the patient left the Vail Valley Vail Health Medical Center, we had used 27 units of packed cells, 17 of FFP, 5 of cryo, and 2 of platelets. So we had a 27 to 17 to 5 to 2 ratio in our very much not balanced resuscitation. But what we were able to accomplish was that at almost all times, we were only transfusing blood products. We had 7 units of packed red cells that were compatible and were able to give the transport team to get them to Georgetown, which is about halfway between Vail and Denver. And that left us with 2 units of blood in the hospital, but allowed them to get the cooler of blood and continue transfusing the patient to Denver Health. Next slide, please. This is what the patient's chest x-ray looked like when he arrived at Denver Health. You can see our packs all over the place. Lungs are still relatively clear. Next. He went directly to the operating room. Denver Health trauma team and University of Colorado transplant surgeon waiting. He had approximately 2.5 hours with the Pringle on. They put him on veno-veno bypass to bypass the liver, evacuated the hemoperitoneum. They completely mobilized the liver. And now this is the solution to our mystery. There was a avulsed venous branch off the right hepatic vein, directly off the inferior vena cava. So that accounts for bleeding with the clamp on. And then he had avulsed his right and left hepatic arteries at the bifurcation above the clamp, which is why it bled torrentially with the clamp off and slowed it down with the clamp on. They were out of the operating room at about 3 a.m. and they initiated continuous veno continuous dialysis in the OR. Now, would it be possible to go back to the slide with the CT scans way back at the beginning? And right there. Now, if you look at the right hand image and you look at the liver, and you will see the hepatic artery going up into the liver. I'm sorry, I don't have a pointer. And that little disconnected area. In retrospect, that is the injury to the hepatic artery, which we were unable to appreciate at the time, because at the time, if the vessels curved away from you, you might not have it in that cut. But in retrospect, that is one half of his devastating injury. Can we go back to where we were, please? And yeah, okay. So now we're going to get to some of the lessons learned in a little bit. Usually, when they ask you to present these sorts of cases, they end with, and they all lived happily ever after. Unfortunately, that is not what happened here, but we thought it was still a really good case to present to show what can happen with a regional system where all the entities are aware of each other's capabilities and have talked about these sorts of things like meeting the cooler blood halfway, bringing blood to us, or having years ago at Denver Health, advice added the cryoprecipitate into the MTP since we don't have platelets, et cetera, et cetera. So post-injury day 1, he returned to the OR at 7 a.m., abdominal washout, diffuse coagulopathic hemorrhaging. They had to ligate his right epigastric artery, packed with combat vas, and he lost another 4,000 cc's of blood. Next. Post-operative day 2, he made it the next 24 hours. They actually explored him at the bedside in the intensive care unit. They removed the packing, took out part of his gallbladder because it had necrosed. There was diffuse oozing over any raw surfaces, and the liver was starting to show necrosis. They did core needle biopsies of both lobes of the liver because now the patient was being considered for transplant, and the transplant service at the university, acknowledging the regional effort to save this man, had said that if he was able to be got into a stable condition with no evidence of infection, they would list him for emergent transplant. Next. And post-injury day 2 in the afternoon, he still had significant coagulopathy. Remember, his liver is dying, so it's not producing clotting factors, and they have to almost continuously transfuse him with cryoprecipitate and FFP. Now he's bled into his chest. They have tube thoracostomies, unsuccessful lavage. They take him to the OR for a right thoracotomy. He returns to the ICU unstable. Next. They continue the dialysis, hypotension. He's hypotensive, he's hypoxic, has a wide complex tachycardia, ACLS resuscitation, cardiac arrest, and succumbed to his injuries and multiple organ failure, unfortunately. Next. So this, my colleague wanted to put this in. Rome wasn't built in a day, and neither are these regional systems built in a day. You have to know the players, knowing people's names face to face as opposed to just the position that they hold is so useful when you start designing these sorts of mutual aid agreements next. So, local regional capabilities and coordination. You need to have preset relationships with your regional tertiary care facilities, EMS, and flights on standby for service when you need them. You need to know your transport capabilities for both to get patients out and to bring um, additional supplies, and blood being the most obvious one. And what are your contingency plans for inclement weather? Can you use law enforcement, state patrol, sharing between blood banks? And I just want to put in a little reminder here that when you look at mass casualty events, or really anybody that's going to require massive transfusion, there are two things that stand out as um, correlating with survival: the time to hemorrhage control, which in this case was almost 6 hours after initial injury because we were unable to achieve hemorrhage control in Vail. I just know from experience that if they have a retrohepatic caval injury and you release all those ligaments without being able to go on bypass or Schrock shunt or some other various total hepatic exclusion, some very complicated aggressive maneuver that you need to have done previously and practiced. So getting back to what I was saying, the two things that stand out are time to hemorrhage control and quality of resuscitation. And quality of resuscitation is how long did it take you to get the blood into the patient? What is the are you able to continuously get blood into them and other blood products as opposed to crystalloid until you have hemorrhage control? And how close can you get to the 1-to-1-to-1 balanced resuscitation, which obviously you see, despite our best efforts, we're even nowhere near that. Next, it's important to know your trauma system and your resources available in and out of your county, and your ability to mobilize these resources and coordinate care across multiple agencies, which you're not going to be able to do if you make it up on the spot. Um, you need to think outside the box and do what you must do, but know how to maximize your capabilities within the limitations of your system. And with that, I think that's about what I have for you. Any questions, feedback, or anybody have any suggestions for how you resuscitate people when you know you cannot achieve that 1-to-1-to-1 resuscitation?
Dr.
Hey,
Young.
Reg. Yeah,
Hi.
Heather Young here. Thank
Hi,
you so
Heather.
much for this really fantastic talk. We really appreciate you.
Well, it
And I
doesn't
think that
really
this,
end well.
it
So,
really doesn't, but I think that this really highlights, just so many different learning points, for our learning community here. So thank you for that. I wanted to take it one step further and ask, you said that you had 2 units of packed red cells left at Vail Health when this patient ultimately left for transport. Tell me about the impact that has to your hospital and to who you can then care for next. Like, can you do elective surgeries? what if a patient with a GI bleed walks through the door of the emergency department? Like, how does it impact your ability to care for your standard patients? And how long does it take for your hospital to recoup all of the blood products?
So, okay, then I'll break that down into several things. So one is you're talking about how do you balance the problem you have for real, right in your face, right now, against the problem you might have 10 minutes from now. And that is a very legitimate thing. So as soon as we're out of blood, so a cooler full of blood is also on its way to us before before the critical care transport is even in Denver. So they're sending us more blood as soon as they can. Is there a gap? Yeah. I mean, if the pass closes, that could be sitting, on the side of the road for quite some time. Um, Again, we're now into the night times, which is better than during the day. So you would then have to look at um, whatever case you're going to do. How emergent is it? Do you really need to do it until the blood's available, or balanced against what's the chances of you needing blood? So for an inguinal hernia that's no one's gotten a blood transfusion for in the last 5 years, probably reasonably safe to go ahead. We were lucky that it was at night, so the elective schedule shuts down. Could we have ended up in a bit of a bind? Yes, absolutely. We still had the option to borrow blood from the west, from the next blood bank being Grand Valley View Hospital in Glenwood, and that's about a 30 to 45-minute drive. So it does impact you. Um, you know, Luckily we can replace it in pretty quick, short order. But the the question you have to answer when you're the one making the decisions is, we've put this much effort into a problem that we really have. How much are we going to sacrifice uh, the potential to actually save this patient against the problem that we might have? And there's no perfect answer to that. Take your best guess and go
Yeah.
with probability.
Yeah. No, thanks for sharing all that. Really appreciate it.
Um, Anybody else? Everybody else in the mountains is able to get this one-to-one resuscitation done?
All right, I'm not hearing much else.
Well, I want to thank everybody for listening. This well, it's kind of cathartic to tell the story. It was one of the harder nights, one of the harder days, one of the harder cases, because the whole community was rooting for this guy, and it was, yeah. After he made it the first 24 hours, people were really thinking that he was going to be okay. Long road ahead, and could they get him the liver transplant, et cetera, et cetera. But, we were past the immediate exsanguination period. So
Guys, let me ask one other question. Do you remember, was this gentleman a local or was he traveling from out of town?
that is a good question. I think that he was local, actually.
Yeah, and
Local meaning not from our town, but um, driven to, as opposed to flew to the ski area, as opposed to flown in.
yeah.
Actually, now that I remember, now that I recall, now that you stimulated that, I think he was from a Denver suburb, um, because I remember um, family saying uh, they knew where to go and this and that sort of thing. Yeah.
Dr. Franchos, how long ago was this? And since we are carrying whole blood now, I mean, it's only 2 units, but would that have had, do you think that would have made a difference in the end, or was it just too many things and just the situation?
Well, this was about 3 years ago now, so I think the whole blood on the system just started this year, just a couple months ago. And if you remember, it took a while for him to get unstable. So
Yeah,
the amount of time that it took from him to get to the from the bottom of the mountain to the hospital, he didn't look bad at all. So he wouldn't have gotten that whole blood. He wouldn't have met the criteria to get the whole blood, though he may have. At this point, if I was in that situation again, I would have called and asked called the supervisor and asked them if I could have their 2 units of whole blood. But yeah, I don't think in this case, because of the proximity to the hospital, you know, um, when he was injured, that in the short distance he was transported, I don't think it would have helped.
gotcha.
Yeah, but it'll help some other people, that's for sure.
Yeah, it has done. So I'm glad.
Yeah. Uh, I think that might be it, Heather. Other questions coming up?
I don't see any others in the chat. Let's see here. I see that Katie has put in here a post-session survey. So anybody who's able to click on that in the chat, we would really appreciate feedback to come on our session. So if you have a few moments, that would be really wonderful. And again, I just want to thank Dr. Franchios for sharing this really challenging case that really touches on so many of the issues that our rural and recreational areas in Region 8 face. And has been able to share so many learning points. So thanks again. Really appreciate you doing this for us today.
All right. Well, um, you're welcome. And I look forward to being a participant. I was telling them before, I look forward to hearing other people's presentations. And my whole career, 30 years, I've never not given a talk where I wasn't standing in front of the audience. So it's kind of a new experience.
Yeah, for sure. So as an advertisement, Ariana and Katie, correct me, I think is it in 2 weeks that we're going to have Mike Russo presenting on another snow-related topic? Do you have his topic right off the top of your head there?
Yeah, so it'll be in the same theme of our January 2026 session. So it'll be when conditions change. So winter sports safety is a model for preparedness planning. So keeping up with the ski theme for January, and all the information should be in the Echo platform if you're interested in registering, and we'll drop that in the chat as well.
Great. And then February, we are focusing on measles, and we have some really fabulous speakers lined up for February. And then March is going to be burns and caustic injuries, as well as blast injuries. And we are lining up some great speakers for March as well. So please do keep an eye out on the Project Echo platform because we're really looking forward to some great upcoming presentations.
I'm sorry. What did you say February was?
Measles.
Oh, yeah, that's a biggie now. And then burns, that'll be great. Burns and blast. All right.
Great. And welcome to the webinar.
Yeah, thank you, everybody, and huge thank you to Dr. Francis, and have a great weekend. Thanks, everyone.
All right.
Thank you.
Bye.
Bye, everybody.